being here. I hope you're all as excited as I am to get the update on what's going on with COVID-19. For those of you who weren't at the original webinar, we had a webinar in May presented by Dr. Brewer that was excellent. We got a lot of great reviews from that webinar, and it was just a dive into COVID-19 and how we got here and what we're doing and where we're at. So we asked Dr. Brewer to come back and provide us an update, since this is such a changing topic. So we're really excited that he agreed to do that and is willing to return and present to us. So as we're going along, I will just a couple of housekeeping things. Everybody is muted, so if you have a question or you want to ask Dr. Brewer something, if you could put that in the chat box. I'll keep track of all the questions as we're going, and then at the end of the slides, we'll kind of run through all the Q&A. So feel free to just, as you're going, if you have questions, put them in the chat, and I'll keep a log of that and bring them up at the end. So I'll give a brief introduction of Dr. Brewer, and then I'll let him kind of take over and run through all of his slides. So Dr. Brewer is a professor in the Division of Infectious Disease at the David Geffen School of Medicine at UCLA, and he's a professor of epidemiology at the UCLA Fielding School of Public Health. He's an authority on using analytic methods to optimize the population-based control of infectious diseases, particularly tuberculosis and HIV/AIDS. He has extensive experience developing and overseeing training, education, and service programs, both locally and in countries around the world, and he has received multiple teaching awards for his efforts. Dr. Brewer has served on advisory boards and review panels for numerous international and national organizations, including the World Health Organization, the NIH, the CDC, and the Canadian Institutes of Health Research. He currently serves as chair of the board of directors for the Consortium of Universities for Global Health. So please join me in a very silent but very welcoming round of applause for Dr. Brewer as he presents this webinar titled COVID-19, an Update.
Thank you very much, Martha, for those very kind words. I'm delighted to be back. I'll try to make sure we have more time for questions at the end today. I apologize, the first one went a little long, so we'll go a little shorter today. And there will be a couple of slides for those of you who were with us in May, where I just repeated because not much has changed, so I'll apologize for that in advance. But hopefully enough new there that it's of interest. So we're going to focus on COVID-19. That's obviously in the news, and let's see what we can learn together. So again, we'll just run a little bit through where it comes from and what it is, but we're going to spend a lot more time today focusing on some of the data behind things we do, like sheltering in place and masks. Why do we believe they might or might not work? And talk a little bit about treatment. I'll give you some updates on where we stand in terms of diagnostics. So for example, the Infectious Disease Society of America guidelines for the diagnosis of COVID-19 just became available this past week. So they're only available in preprint. They're not actually peer-reviewed and published yet, but that's how fast everything is changing. So we'll try to keep you up to date as much. And then we'll end just by briefly talking about what's happening in the vaccine world. But the short answer is I don't expect us to have a vaccine anytime real soon. So as you remember, COVID-19 is caused by a virus called SARS coronavirus 2, and SARS stands for Severe Acute Respiratory Syndrome. And it is the second SARS virus to be so named. The original one was recognized in 2002, 2003, and caused an outbreak that led to about 8,000 cases, about 800 deaths. All coronaviruses are RNA viruses. The reason that's important, as we touched on briefly last time, is that RNA viruses tend to make mistakes when they replicate. And so that means they mutate and they change over time. Coronaviruses are a little unusual compared to other RNA viruses like influenza viruses, and HIV would be another example of an RNA virus, in that they're really quite large. They're among the largest of the RNA virus, and they do have a proofreading mechanism. So they don't make as many mistakes as, say, HIV or influenza. There are four major categories of coronaviruses that we know of: alpha, beta, gamma, and delta. And the human diseases all come from the alpha and the beta coronaviruses. And in general, they tend to cause respiratory tract infections, and they cause gastroenteritis in animals. And some of these coronaviruses are actually very important viruses in the veterinary world, can cause severe outbreaks among farm animals, for example, a severe gastroenteritis in pigs. And so it's a very important disease in animals. Before SARS in 2002, we didn't really care much about coronaviruses too much. There had been 4 coronaviruses that had been described in humans, and those are these 4 up here that all say HCOV. And the important thing to remember is humans are not the natural host of coronaviruses. So all coronaviruses originally start in some other animal, and the majority of the ones that have gotten into humans have come from bats. But we also have a couple that come from rodents. And one reason that is there's just a lot more of these than there are of us. So rodents, rodentia, are actually the most common mammalian species in the category of mammalian species in the world. And bats are actually number 2. So 1 out of 4 mammalian species in the world is actually a type of rodent, and 1 out of 5 is a type of bat. So just between rodents and bats, they account for almost half of all mammalian species in the world. So these are the natural reservoirs, and we're going to focus on these 3 down here. They all originally came from bats. So the first one is the SARS coronavirus, 2002-2003. And this was our first experience with a deadly coronavirus. The mortality rate of this virus was about 10%. Fortunately, this outbreak ended after approximately 6 months. Our second experience with a serious bat coronavirus was the Middle East Respiratory Syndrome coronavirus, or the MERS coronavirus. And this virus is actually still circulating in the Middle East. So the secondary host is dromedary camels, and dromedary camels do not seem to get particularly sick with it, but they do have high viremias. You can isolate the virus from a number of camel body fluids, and that unfortunately facilitates the transmission from camels to humans. And so we continue to have cases of MERS virus, fortunately not the big outbreaks that occurred with SARS or SARS-CoV-2, the current COVID-19 virus, because this particular virus has a mortality rate of about 34%. So this is a very, very deadly virus. And then the last one we're going to focus on is obviously SARS-CoV-2 that's causing the current COVID-19 pandemic. It's about 80% similar to the original SARS-CoV virus, and both of these viruses bind to the ACE2 receptor in human cells. Unfortunately, SARS-CoV-2 binds about 20 times more strongly than the original SARS coronavirus, and that probably helps to facilitate its transmission among humans. The other unfortunate aspect of this infection is this is a receptor that's found in a lot of cell types. So it's found in endothelial cells, it's found in lung alveolar cells, heart cells, kidney cells. It's a very common receptor throughout the body. So as we talked about last time, it is a respiratory virus, and so the primary transmission is by what are called respiratory droplets. So these are combinations of phlegm, sputum, mucus, and virus that tend to be in the range of about 2 to 5 microns. And the reason that's important is that those particles those size tend not to float in the air for long periods of time. So they tend to travel a short distance in the range of 3 to 6 feet and then impact on individuals or surfaces. And that's the primary mode of transmission for SARS-CoV-2 as well as influenza, which is not to say you cannot have airborne transmission, because when you produce particle sizes, there's obviously a range, some larger, some smaller. And there are data to show that there can be SARS-CoV-2 airborne particles. So there can be particles that can suspend in a room for hours on end. And in theory, if some individual who was infectious with SARS-CoV-2 was coughing in a room and then left, and then a susceptible person came in an hour or two later, they could inhale those particles and become infected. However, we don't think that's a major contributor to transmission at this time. So we still think that person-to-person contact is important, and I'll show you some data as to why that may be. The other thing to remember is viruses can live on surfaces, usually in the order of hours to days. And so if a surface is contaminated with respiratory droplets and someone comes in and touches those surfaces and then touches eyes, nose, mouth, they could self-inoculate and then get infection. And while we think that does clearly happen as well as airborne transmission, again, we don't think it's a primary mode of transmission for SARS-CoV-2. And the last thing to remember about transmission is that transmission can occur before individuals get sick. And we actually think that as much as 40% of transmission may be due to what's called asymptomatic or pre-symptomatic spread, not because those people are more infectious, and I'll again show you some data for that, but because there are just more of them. So as you remember, about 80% of people tend to have mild to moderate disease. And so because there are many more infected people with mild disease, the attributable risk, the risk to the broader population is substantial from this group. But in fact, there are some data to suggest that sicker people are more likely to spread it. So let's look at some of that too. So just to go back, we remember this was originally reported in Wuhan, China. There had been exposure to a seafood market, and because this virus binds to ACE2 receptors, which are found in many different cell types in the human body, it can be found in pretty much all body fluids, but we really think it's the respiratory droplets, not stool or other body fluids or blood, that are really causing any significant transmission. As I mentioned, about 8% of people have mild to moderate disease. Roughly about 16%, 15–16% end up in the hospital. And the mortality rates have been bumping around a little bit. In this original study, they had about a 1.5% mortality rate. Globally, the mortality rate has been running between about 3.5% and about 6%. And we're running about 3.5% here in California. So what's happening now? And what I really want to do is focus on these two slides for a little bit. So this is new cases in the United States, basically from the beginning of the epidemic up and through until I think like Monday I made this slide, or Tuesday, so a couple of days ago. And then over here, you're seeing the exact same thing for Los Angeles County. The light bars are the cases, daily cases. The very dark blue bars are daily deaths. And this is the daily case fatality rate. And the critical take-home message for both of these graphs is that SARS-CoV-2 or COVID-19 never went away, right? So people are talking about, will we have a first wave, a second wave? Well, the absolute truth is we have never gotten out of the first wave, right? So we peaked somewhere around, oops, sorry about that. We peaked somewhere around 30,000 cases a day here in April and early May. And it came down a little bit into the mid to low 20s. And now over the last last week or so, it's been starting to go up again. But in fact, you can see it never went away. So we've never gotten this virus under control to the extent that some other countries have, which is not to say some places have not gotten it under control. So you've probably heard in the news about the success that New York, New Jersey, and Connecticut have had in bringing their case numbers down. So there clearly have been some success stories around the country, but as a country as a whole, we have not been able to contain this virus. Likewise, in LA County, it's never gone away. So our case rates have basically never come down. It's a little hard to see on this graph, but death rates have come down and hospitalizations came down from the peak of late April to mid-May. And that's part of why we relaxed our shelter-in-place orders, because case rates are actually not one of the criteria that are used for relaxing shelter-in-place orders, but hospitalizations are and amount of ICU beds filled are. And so both of those did come down, but case rates have actually really never come down in LA County. So just an important thing to remember when people talk about, will we have a second wave, is the reality that we actually have never gotten out of the first wave. So I mentioned there's some new data to suggest about transmission risk, and this is one of those studies. So this is a study out of Taiwan where they took 100 people with documented laboratory proven COVID-19, and they traced all of their contacts, not just their household contacts, but work contacts and other contacts. And close contacts were defined as people who spent about 15 minutes in contact with someone, basically in the same room. So, you know, within a 6-foot radius of other people. And a couple of take-home messages. The first is that out of these 100 patients, they found almost 2,750, just over 2,750 contacts. So just to remind you, we all have in the course of our days a lot of contact with other individuals, and yet the transmission rate overall was pretty low. It was under 1%. So they only documented 22 secondary cases of COVID-19. The second thing that was very interesting about this study is no cases of transmission occurred after 6 days of symptoms. So all of the 22 people who were found to have COVID-19 have been exposed to someone who had been sick for either asymptomatic or pre-symptomatic, or who had been sick for less than 6 days. And actually, I think in this particular study, they did not have any cases of asymptomatic transmission, but we do know from other studies that asymptomatic transmission occurs. Household contact, not surprisingly, was associated with the risk of transmission, and that's been shown in a number of studies now. And the other thing that came out was, in fact, severe disease was more likely to be associated with transmission. And this is something we saw both with the original SARS and with MERS. And so while we have been focusing on asymptomatic transmission in the media because there are so many people who are asymptomatic, it does look like sicker people are more likely to be contagious. And so that's just to be important for all of us healthcare workers to just remember and to make sure that we be we be careful about using our personal protective equipment and following infection control guidelines when we're working with individuals who may have COVID-19. This is a study out of Iceland that, again, recently came out. I just wanted to point on a couple of things. So they did two things in this study. One is they did targeted testing, and so this was testing of individuals who had a high risk of having COVID-19. And by high risk, it was people coming to Iceland from areas like northern Italy, where there were outbreaks of COVID-19 going on, or and were symptomatic. So these were not asymptomatic individuals, they were symptomatic individuals, or they had been in contact with a known case. And the first thing to show just is that there were a lot of people they had to test, but as you can see here, the positive rate was substantially higher than what we saw with the Taiwan study. And this is in line with studies in China among household contacts. So I think where there is prolonged exposure, this is probably somewhere in the 12 to 15% risk of transmission is a reasonable one. The second thing I want to point out just over here is just that across the age group, basically anybody can get infected with this disease. So we'll talk about who ends up in the hospital a little later on, but it's not that young people or even kids cannot get infected. They actually do get infected. They're just not as likely to manifest serious disease. But it is important to remember that young adults, adolescents, and even children can become infected and therefore could be contagious and spread it to others as well. The other thing just interesting to note is that men were more likely to be infected for whatever reason than women. A lot of interesting work going on to try to sort that out, but still not entirely clear. The other thing they did was a random sample of the population, and then their much lower rates of positive test on the order of what we saw in the Taiwan study. And here, very few infections in children and adolescents. So really it's young adults and adults in general in the random sample of the population. But we know from contact studies, children can get infected. So now let's talk about some of the things that we're doing to try to prevent transmission from occurring. And we'll focus a little bit on what are the data around the public health responses, including case identification and contact tracing, and then some of the recommendations that we've been making around things like facial covering and hand washing, and are there any data to suggest that the shelter in places have been beneficial. So there are no randomized controlled trials to help us for any of this, so we are going to have to rely on observational data and ecologic studies, but they do tend to be fairly consistent, and I think there is reason to believe that they may be in fact reflecting real outcomes. So this is just, these are data looking at countries that have been felt to have effective contact tracing programs. So China, Israel, and South Korea are three examples of countries where they think they're doing a good job about testing people who may be symptomatic or exposed, rapidly identifying people who are infected, putting them in isolation, and then tracing their contacts, testing those contacts, and then either quarantining the contacts or following the contacts. Just to remind ourselves, so isolation is what we do for individuals who are symptomatic. So if you're sick, you go into isolation. Quarantine is what we do for people who are asymptomatic. So you're exposed, we're worried you might become infectious, so we put you in quarantine even though you don't have any symptoms right at the moment. And then the bottom half are 3 countries where they have not been as effective in terms of case testing and identification and tracing. And basically just to see, and these are all rates that are adjusted per million population to just make them more comparable. So they're not actual case numbers, they're case rates. And yeah, as you can see, the case rates and the case fatality rates in the countries that have been less effective are anywhere from 10 to as much as 100 times higher than in countries where they have been effective. So just some data to suggest that, in fact, contact tracing can be an effective strategy if you do it well. So what about hand washing? And so we, not surprisingly, no studies of randomizing people to washing their hands or not washing their hands. So in general, we just tell people to do it. But there are some data to suggest it's a beneficial thing. So this is a study that was just recently published in the last few weeks, looking at, now this is a low pathogenic avian influenza virus, so another RNA virus. They did not use SARS-CoV-2 for reasons. You actually need a BSL, a biosafety lab, level 3 lab to culture and isolate SARS-CoV-2. So that's why most laboratories don't do that. And most researchers look for other viruses that are safer to work with in the laboratory. So they used an avian influenza virus. And basically what they found is if you just take a wet towel and you put soap on it or sodium hypochlorite, which is a type of disinfectant, you can pretty much wipe out all of the virus. And so just some nice data to suggest that, yes, in fact, hand washing should help to clear virus off of your hands. The other thing they did, same investigators, is they took basically cloth masks, surgical masks, and N95 respirators, and they sort of create a mock-up of a mouth and then shot virus through the different types of masks onto culture media to see how much virus actually got trapped. And again, you can see that in general, even homemade masks work very well in catching those respiratory droplets. So remember, we had talked about the part of the reason for encouraging facial coverings is that people can be asymptomatic and infectious, meaning they can spread the virus. And by covering their face, hopefully that covering is impacting catching the virus particles that are coming out of their nose and mouth, preventing those particles from landing on another individual or landing on a surface. And so just some data to suggest, yeah, these things probably are doing something, at least in the laboratory. So what about actual studies in humans? And again, no trials, but there are an increasing number of observational studies that have been published, over about 20 now. And this is actually a meta-analysis that just came out this month in the Lancet that pulls together data from those different observational trials. And they looked at 3 different prevention measures. One was physical distancing. Because they're in Europe, they use meters, but a meter is about 3.3 feet. And face masks and eye protection. And as you can see, all of these are actually quite effective. So that if you're just 3 feet away, your transmission risk goes from about 13% down to about 3%. So that's just over an 80% reduction in transmission just by being a little more than 3 feet away from an individual who may be infectious. and also highlighting the importance of that person-to-person transmission. And there was a dose response curve so that if you moved farther away, the transmission risk dropped even lower, but there weren't enough data to do a formal meta-analysis. In terms of face masks, again, they had about an 85% reduction in transmission from wearing a face mask, from 17% down to 3%. And again, a dose response curve. So N95 respirators seem to be more effective than regular surgical masks. So again, the better the mask, the more likely the protection. And then wearing some kind of eye protection was also beneficial, not quite to the same level as a face mask or physical distancing, but again, highlighting the importance of inoculation of virus on mucous membranes, including the conjunctiva of the eye. And so some nice observational data to say, yes, these prevention measures that the CDC and public health departments are recommending have some evidence to support them. The caveat being that this is felt to be low quality evidence because these are not randomized controlled trials, they're observational studies. So just do keep that caveat in mind. So what about shelter in place? So the first question about shelter in place is, well, do people actually shelter when you say shelter in place? So these are data from the CDC looking at mobility in LA County. And so our shelter in place order went in somewhere around here. I think it was March 19th, but don't quote me on the exact day. But you can see, in fact, yeah, people actually started staying home. And so percentage of people going to workplaces dropped 39%, retail was off 33%, mass transit's big down, a lot more people are staying home. So the mobility index refers to how far do people go in the course of the day, and you ask how did they get these data? They actually got these data from your cell phone and my cell phone. So basically, this is saying, where did the cell phone go relative to home base, right? And if you have a mobility index of 3, that means that your cell phone has not moved more than 1 kilometer from home over the course of a day. And a mobility index of 4 means that you have moved 10 kilometers, which is about 5 miles. So basically, most people are moving somewhere between staying at home and less than 5 miles. So their cell phones are not out there traveling. And if they're traveling without their cell phone. So what did that do in terms of impact in California? So some data suggests that, in fact, yeah, that actually had benefit. So this is a study. It's a working paper. It's not yet been published. So we're still waiting for the peer review publication to come out. But as you can see, these are pretty substantial reductions. To put this in perspective, in April, we were running in Los Angeles County about 400 cases per 100,000 population. So that's somewhere between 30 to 50% reduction in COVID spread. Unfortunately, right now we're up around 820 cases per 100 population, but still that would be a 25% reduction if we were hitting that. And there did seem to be a reduction in deaths as well, around the same order of magnitude. They did try to control for potential confounding factors. So remember, confounding factors are just factors that may be associated with a exposure and an outcome and could influence the outcome. For example, you do a study looking at whether or not people who carry lighters and matches are more likely to have lung cancer, and you find out lo and behold, they're much more likely to have lung cancer. Well, the confounding factor there is obviously cigarette smoking. So cigarette smoking is likely to be associated with the exposure, carrying matches or a lighter. People who smoke are more likely to carry matches or a lighter, and with the outcome. So that's a confounding factor. We try to control for them in observational studies. You can't always do that completely or well, but that was a reasonable attempt here. The other interesting piece of data is just that it got more effective over time. So in fact, over the second or third weeks, and this was a study that looked at the first month of shelter in place, so only 4 weeks of follow-up, but by the second or third week, they were seeing a bigger impact than they had with the shelter in place after the first week. But obviously, this was not cost-free, and they did do some estimates of how many jobs were lost per case of COVID averted and how many jobs were lost per every life saved. And so they did try to look at that balance between, okay, what's the adverse events, if you will, of this particular intervention. But data to suggest, in fact, shelter in place did do what it was designed to do. So just to remind us, the incubation period, anywhere from 1 to 14 days, but in general, about 5 days or so. Fever, cough, trouble breathing are the most common symptoms, but you can have unusual things like loss of smell or taste. That seems to be more prevalent in young individuals. I don't know why that is, but important to remember that's actually not unique to COVID-19. Other respiratory viruses can do that as well. And so none of these symptoms are specific for COVID-19, and that's why testing is so important to make the diagnosis of COVID-19. Rhinorrhea or runny nose is less common, and we have seen cases of vasculitis, and we can talk a little bit about in the question and answer period as to what may be going on there. So as of May 30th, this was a study done by the CDC where they looked at more than 1 million cases in the United States, 1.3 million cases between January and May 30th. And our numbers are very similar to the numbers that came out of China that I showed you earlier, that approximately 80% of 85% of people do not require hospitalization. They have mild to moderate disease. 14% hospitalized. Our mortality rate was 5.4% at that time. I think it's actually come down a little bit, but importantly, much higher mortality rates in people with underlying conditions. We'll talk a little bit about which ones in particular. Individuals without comorbid medical conditions, much lower mortality rates, and about 2% end up in the intensive care unit. And early on in the study, our mortality rates nationally for patients in the ICU were actually about 50%. They have come down a little bit. I don't know what they are here in Los Angeles. I know at UCLA, they've been substantially lower than that, which is good. But if you're in the ICU on a ventilator, that's bad. But we'll talk about some of the exciting data around treatment that may bring some promise there. So as we've known for a while, age is a very important risk factor independent of everything else. So you can see here that if you're over the age of 65, your risk of being hospitalized is about 80-fold higher than if you're an adolescent, and it's about 4.5 times higher, even if you're an adult between the ages of 18 and 49. Interestingly, unlike most other respiratory viruses, while the rates are higher in the very young, and this really is neonates and infants. So if you break these data out, the peak is really under 1-year-old, so probably a population that you're all dealing with. So to be aware of, but still much less common than we see with other respiratory viruses. And there's some data to suggest that infants and young children have fewer ACE2 receptors on their blood vessels and other cell types. And so that may be one of the reasons why we're seeing less disease in young children and infants, but they definitely can get it, and they can get serious disease too. So do think about COVID-19 if you have a sick infant. Race and ethnicity, also important risk factors for serious disease and mortality, for death. So you can see Native Americans, highest rates. We don't talk about that much in the media just because the Native American population is relatively small relative to other racial and ethnic groups, but a critical problem for our Native American populations right now. A series of outbreaks going on, for example, in the Navajo Nation. And really, we have to do a much better job trying to get that under control. There's been a lot of talk in the media about Black and African American rates, higher rates of hospitalization and mortality. So you can see here the hospitalization rates are about 3.5, 4 times higher than non-Hispanic whites. And again, we can talk a little bit about that. Important for California and Los Angeles is the high rates among Hispanic or Latinx populations. And that's what we're seeing too. Our case rates in California as a whole are not particularly elevated in African Americans and Black, but they are elevated in Hispanic and Latinx populations. Our mortality rates are up though in Black and African Americans in California as well, though not again quite as high as our Hispanic and Latinx population. So really, the structural racism and inequality that has existed for centuries being exacerbated by the COVID-19 pandemic. So what are those comorbid diseases? The most important one is hypertension. Some evidence to suggest that hypertension may upregulate those ACE2 receptors that the virus binds to. That may be one reason why hypertension is such an important comorbidity in serious disease, but it also includes diabetes. So that's a metabolic disease here. Obesity is another very important one. Very low rates, as I said, of hospitalization among individuals with no comorbid disease. So among adults, so the light bars are pediatrics, the dark gray bars are adults. Among adults, under 10% hospitalized who have no known comorbid diseases. So those comorbid diseases are very, very important. What about happening in California? So this is just from a couple of days ago. And all these are data, if you want to actually, the California and the LA County public health websites are really quite excellent. If you do want to go on and look at them and see updates. So first thing is, we have a lot more cases than anybody else. This is total numbers. These aren't rates, so you can't really compare them by population. In terms of rates, actually, the highest rates in the state are Imperial County has the highest rate, and Kings County is number 2. Los Angeles is number 3. But I should probably know this, but I don't know where Kings County is. But the case numbers are kind of small, so I assume there aren't as many people there. But Kings County does have very high case rates. But the important take-home message here is that you can see that. So this is ICU data, and you can see that while it came down a little bit, it's never really gone away, right? So Suspected came down much more as our testing got better. And you can see here, positives, again, we've had a little drop. But in fact, we've never really gotten this pandemic completely under control. Among hospitalized patients, tends to be about 13 days, 12, 13 days to onset of shortness of breath. The important thing to remember is that COVID-19 patients can do well for about 10 to 14 days and then suddenly decompensate very quickly. So you're not out of the woods for someone who has been sick for 8, 10, 12 days. You do need to keep an eye on them, maybe have them get a home pulse oximeter to check their O2 saturations, have them check in with you or another healthcare provider once a day, just to make sure they're doing okay, because we have seen this sudden decompensation in individuals with COVID-19 with rapid onset of dyspnea and shortness of breath. So what do we do to diagnose it? Nucleic acid amplification these are the PCR-based tests. They broadly fall into two major categories. The laboratory-based tests, those take anywhere from about 2 to 13 hours to get a turnaround time, and then the point of care test. So we do have nucleic acid tests available that could be done as point of care tests. Those are what's called the rapid tests down here. These are from those same Infectious Disease Society of America guidelines just published this past week. The important thing to remember is the rapid tests are not as sensitive. So remember, sensitivity is the ability of a test to be positive when disease is present. So if you have a positive test, then that's COVID-19. So the tests are very specific. If you have a negative test and you're using a rapid test, the person could still have COVID-19. So if you have a high index of suspicion and you do a point of care test for COVID-19 and it's negative, you might consider repeating it or doing a laboratory-based test for COVID-19, because the rapid test will miss some people. But if you do have a positive test, you can be assured that is COVID-19. It's not cross-reacting with another coronavirus, for example. The early data suggests that the nasopharyngeal swabs are better than the throat swabs or saliva. Hopefully, technology will improve over time, because, as you know better than I, sticking nasopharyngeal swabs in people is kind of like doctor torture. It's not a very pleasant experience. So what about antibody testing? So serology not to be used for acute diagnosis. If you think someone has COVID-19, you're worried about it, you want to make sure that you're doing those antigen-based tests. They tend to work very well. Most people will develop antibodies. I'll show you some additional data in addition to these data, but it takes anywhere from 2 or more weeks before those antibodies show up. So particularly early on in disease, antibody testing is not an effective test. And in fact, it's hard to recognize IgM antibodies, and the IDSA guidelines that I mentioned do not recommend IgM antibody testing for acute infection, even though we do that sometimes for some other viral infections. So antigen testing for acute infection, antibodies just if you want to know if somebody had it. The downfall of the antigen testing is it can remain positive for a long time, and that does not mean someone has infectious virus for that whole time. So in this particular study, about 20% of people were still antigen, so that's PCR positive anywhere from 3 to 14 days after their symptoms had been completely resolved. The longest out was almost a month, but we have not yet been able to identify infectious virus in people much after about 10, 12 days. And there are only some early studies doing that. And if you remember those Taiwan data that I showed you, there was no transmission in that particular study by anyone who had been sick for more than 6 days. So the fact that you can still isolate PCR positive virus pieces does not necessarily mean that these people remain positive for long periods of time and remain infectious for long periods of time. So probably do not want to be repeat testing people unless you need that for them to be clear to go back to work or something like that. In general, you want to follow their symptoms and then the CDC guidelines on if it's been at least 10 days and they've been afebrile for 3 days and their other symptoms are improving, then they should be allowed to come out of isolation, go back to work, or do whatever else. So what about these antibodies? Are these neutralizing antibodies? So neutralizing antibodies are the ones we want. They prevent infection of new cells. So these data from the outbreak on the Teddy Roosevelt. So here you can see about 60% of those tested had generated antibodies, and this was about 2 weeks after the outbreak. So remember, most of them probably will, but they just need more time. And of those that had antibodies that they checked for neutralizing, about 60% were in fact actually neutralizing antibodies. What does that mean? So this is data from a mouse model. This is a patient who had COVID-19. They identified 4 different antibodies, and they then injected these antibodies into mice and then infected the mice with COVID-19. And what you can see here is, so here's the weight of the mice beforehand. The blue is the control, the green and the red are 2 different antibodies from a COVID patient. So all the mice get sick, but what happens is that the mice who got the antibodies tend to regain weight again, particularly this particular antibody called B38, and the controls remain sick. And then if you actually sacrifice the mice and look at their lungs, you see a lot of disease in the mice that got control and much less disease in the lungs that got the antibody. So in fact, suggesting particularly this B38 antibody is protecting cells from becoming infected. In terms of treatments, remdesivir remains our only FDA antiviral treatment, seems to shorten duration and symptoms and hospitalization, seems to work better early on in disease, but that is a subset analysis. And in fact, it's FDA approved for any hospitalized patient with COVID-19. But the recommendation is to try to give it as soon as possible. And the company that makes remdesivir is actually working on an inhaled form. There's no oral form available, but they're working on an inhaled form for outpatients. But at least at the moment, it is only intravenously available. In terms of hydroxychloroquine, which has probably gotten the most press, other than remdesivir, there are now 2 studies that have come out. The recovery trial from the UK, essentially no benefit in hospitalized patients. This is still in preprint. It has not been actually published, so the data are not peer reviewed, but this is an outstanding trial of, they used over 100 National Health Service hospitals and randomized controlled trial. So I think these data will hold up once they're actually published. And you can see the mortality rates among the people who got hydroxychloroquine, no difference than people who got standard care. This is a second study. This was done in the United States and Canada among primarily healthcare workers exposed to to COVID-19 patients. And so they randomized them to either get hydroxychloroquine prophylaxis or not. And then they didn't test people, so that is a weakness of this study. It was just COVID-like illness. But again, no difference between people who got the placebo, I think was folic acid in this study, between folic acid and hydroxychloroquine. So still some ongoing trials, but no evidence to suggest that hydroxychloroquine really will have any role in COVID-19. The other big news just came out from the recovery trial is dexamethasone, a type of steroid. We use it a lot for inflammatory reactions in our hospitalized patients. And again, we haven't seen all the data yet, but a 35% reduction in mortality for patients that have been on ventilators and a 20% reduction in mortality for patients who required oxygen. No benefit for patients who did not require oxygen or were on a ventilator. So this is not an outpatient strategy, but for our most seriously ill patients, these are the first data to suggest that you can actually lower mortality with a pharmacologic intervention as opposed to excellent supportive care, which is also beneficial. Number of other things being studied, but I won't really dwell on them now, so we have lots of time for questions. And then finally, just a lot of work going on vaccines. I won't dwell on it in particular, other than to say the DNA vaccine and the messenger RNA vaccines are actually in human trials now. They do seem to generate antibodies and to generate what we believe are those neutralizing antibodies. There are a number of other approaches that are being taken. I think at last count, there were some 120 different vaccines under development. There are 5 major approaches that are being sponsored by the National Institutes of Health. I think we will have a vaccine at some point, but I'm not sure that the first vaccine that will be available will necessarily be the best. So what I'd like to do is stop there and make sure we have lots of time for questions. And thank you very much for having me again. And let's dive into the questions.
Great. Thank you so much, Dr. Brewer. This is so interesting and helpful to hear your perspective on this. I think we all get a lot of information kind of thrown at us, and it's nice to have somebody who can translate it for us. So I really appreciate it. If anybody has questions, you can just go ahead and put those in the chat, or you can unmute yourself and ask, whatever works best. But everybody is muted, so we won't be able to hear you until you actively unmute yourself. So we'll start maybe with just anybody putting them in the chat, and as we're waiting for some to come in, I have a few. So
Sure, fire away.
Okay. I have a question about the antibody test. So, if you get the antibody test and or you're identified as having these antibodies, does that then mean you're not likely to spread the virus, or you can't spread the virus anymore?
So the antibodies are developing later in the course of disease. So it tends to show up after about 2 weeks. And at least the data from Taiwan and elsewhere that I showed you would suggest that by 2 weeks, most people are probably not contagious. So if you're at a point where you are generating antibodies, at that point, you're probably unlikely to spread the disease. The one caveat there is the seriously ill patient. So the patients who are in the hospital, particularly if they're in the intensive care unit, there's probably ongoing viral replication in those individuals, and those patients may remain contagious. But in the community, by the time you're generating antibodies, you're probably not contagious.
Okay. Do you have any sense of how available those will be, and if that's going to be a good method for figuring out kind of how to go about life again, if testing for antibodies is going to be the solution versus a vaccine, since that will take so long.
Sure. So I think right now antibody testing is really primarily for the public health department, right? To get a sense of how much spread is going on in the population. And there have been two studies in California that have been done. One done by a group at USC and Stanford, done in Long Beach, where they looked at about 800 individuals. This was published in JAMA a couple of weeks ago or a month ago now. And they found that about 4.5%, I think it was 4.65% when they adjusted for everything, of individuals seemed to be antibody positive, suggesting a lot more community transmission. And this was early April, like April 10th, 11th, around then. A lot more community transmission that we were aware of. The second was a study done in Santa Clara County by the CDC, and there the rates were under 3%, but I think like 2.5 to 2.8% of the population felt to be positive. So I think that's the main role for antibody testing right now. There are people who are talking about using antibodies as essentially immune passports, that, if you're antibody positive, you're protected, and then you can go to Disneyland or do whatever you want. But I don't think we're there yet. So I wouldn't use antibody testing for that purpose yet. But apropos your question, it does look like people generate neutralizing antibodies. And the issue is just going to be how rapidly is the virus mutating. So, for example, the antibodies we generate to measles, which is also an RNA virus, is lifelong protection. Whereas the antibodies we generate to influenza, because the neutralizing antibodies bind to the hexaminidase, which is think of it as the spike portion of the influenza virus, because that portion of the virus changes so much as the virus replicates, the antibodies that we have don't protect us from the virus the next year, not because they wouldn't bind if the virus were the same, but because the virus has changed. And that's why you have to get a flu shot every year. It's because that virus keeps mutating a little bit, so you need a new set of antibodies. And we just don't know with COVID-19 whether that's going to happen too, because those neutralizing antibodies so far, and actually most of the vaccine targets so far, are focusing on the spike protein of the COVID-19, particularly the end of the spike where it binds to the ACE2 receptor. And that's probably the most mutagenic part of the virus. That's probably the part of the virus that changes the most.
Okay, that's great. That's really interesting. Thank you for answering my questions for me. You bring me there. We do
Sure.
have a couple in the chat, so I'll start running through those. The first one says, can you talk more about the rate of the false negatives on the test? I've read articles stating that the false negative rate is anywhere from 20 to 65%, depending on when the test was given from the date of exposure.
So a terrific question. Depends a lot on the test that's used. So the false negative rates are really high with those rapid tests that I talked about. So those, the Abbott one in particular, I think has gotten a fair amount of press, but there are others as well. So the point of care tests can have higher false negative rates than the lab-based reverse transcriptase PCR test. So if you're working in a clinic or you're working in patients in their home and you're using a point of care test and it's negative and you're concerned this patient has COVID-19, do not take them out of isolation, and do see if you can get an NP swab and send it to a reputable lab to get it run there. So the recommendation there would be, if you're really worried and you have a negative test, repeat the test, preferably with a RT-PCR based NP swab. That would be the best specimen to get.
Okay, great. And then the next question, it sounds like staying 3 to 6 feet away, wearing a mask, and interacting for under 15 minutes with a COVID positive person reduces your risk of contracting it greatly. Is it possible to give the number/percentage to the risk of contracting the virus with those precautions in place?
So, it looks like it just based on the combination of the observational studies, each one of those was bringing it down in the range of 2 to 3%. So presumably, though we don't actually know this, they're additive. So if you're doing all three, for example, that's probably better than only doing one, particularly if you're adding the hand washing as well. So I think a general rule of thumb, but I don't have great data, is probably under 1%, right? Because we know from that study in Taiwan that, and these were contacts of exposed patients, that it was 22 documented infections out of 2,700 people, so that was under 1%. And so I think that if you're doing all of those steps, your risk is probably under 1%. And how much under, I would just be guessing.
Okay. Well, that's good though. Those are good. Sounds like those are useful ways to combat it.
Definitely.
Can we go back to the slide about the comorbidities? And Saba has a couple questions. So I don't know, Saba, if you want to type more questions in the chat, or if you want to unmute yourself and just ask. You asked to review these slides. So if there was something specific, or you just wanted to look at them again. Let me see if I can unmute you. Okay. I don't know if you can talk yet, Saba, but you are unmuted if you have questions you want to ask. Oh, okay. Just wanted to look at them again. So from what it looks like on here, the big, like you said, the biggest one's hypertension.
Right. So just to remind ourselves, whoops, a very sensitive finger here. Trying to make the mouse show up, but I don't see the little arrow anywhere. I don't know if you guys can
Yeah, we
see it.
can see it. Yeah.
Oh, I can't see it, so I don't know where it's going. But the dark gray bars are adults. The light blue bars are pediatric, and the red is pregnancy. And I don't know why they consider pregnancy an underlying medical condition, but that's for the CDC to decide. So what you can see, I think the big take-home message here is that about half of the kids have no underlying comorbid disease. So that's just important to remember. You don't need to have underlying comorbid disease in children. But it's unusual in adults not to have underlying disease. And obesity, I think, is important in both kids and adults. So that would be, and obesity was, I believe, the most common underlying disease in children, even more so than asthma. So do keep an eye on your overweight patients if you're concerned about COVID-19.
I see. Thank you for going through this again. This is really
Sure.
helpful. Okay, good. Saba says thank you. So I think we got the questions answered there. Okay, another question for you. Do you have any predictions about when the first wave will end and the second wave will begin?
Yeah, I'm actually worried that we're never going to get out of the first wave before the second wave, right? So I think the point I was trying to make with the slide earlier on about cases in the US and particularly cases in LA County is transmission has never really gone away, right? So people are talking about first waves and second waves, but it's all the same wave. And what's happening in the country as a whole is we're seeing it really take off in Arizona, Texas, Florida, some other places. but actually it's taking off in California too. So I believe yesterday California was over 7,000 cases, our highest case number since the start. And LA, still about half of all the cases in California are happening in LA County. So we still remain the epicenter. And as I said, our case rates have gone from about 400 per 100,000 to over 800 per 100,000. So despite everything we've done so far, while we have managed to push down hospitalizations and deaths, we have not managed to get transmission really under control. And I am concerned that hospitalizations and deaths will start to rise again as well. And in fact, on the LA County Public Health website, it did look like for the last 3 or 4 days, hospitalizations have started to tick up again.
And just to be clear, because I think sometimes I hear a counter argument to that is, well, LA County has the highest population, so of course the rates are going to be higher, but those are adjusted for population, correct?
Exactly. That's the difference between a rate and a number, right? So the number, if you look at the numbers, LA County has thousands, and like King County, right? So King County, I think, had like under 50 cases. But when you adjust for the population of King County, their rate is extremely high. I think it's over 1,000 per 100,000 population. So higher even than LA County, but they don't have a lot of cases because as I said, I don't know anything about King County, but apparently there must not be a lot of people there. So that's why it's important to look at the rates rather than the absolute numbers, because it does control for population size.
Okay, great. Yeah, thank you. That's it for our chat questions, but I have a couple more. We'll see a few more come in as I'm asking. Do you know much about something that I've heard, and I embarrassingly don't know much about it either. So I'm hoping you do. I've heard a lot about this difference between like an East Coast and a West Coast strain. Is that true? And is there like science behind that? And then what are the differences, if there is?
So as I mentioned, RNA viruses will change, they will mutate as they replicate, because all RNA viruses make mistakes. And the important thing to remember is the vast majority of the changes have no impact on the virus. So they don't make it more infectious or more virulent. They're just random changes in the virus that may or may not be propagated. What we worry about is we worry about mutations that will either make the virus more infectious. So for example, we know the SARS-CoV-2 virus is able to bind to an ACE2 receptor about 20 times greater than the SARS coronavirus. So the mutations that occurred in the stalk of the SARS-CoV-2 virus are ones such that it's a much more efficient binder to that cell receptor than the original SARS coronavirus. Mutations can also make a virus more virulent or more deadly or less deadly. So the mutations that have happened so far, at least as far as I'm aware, and I'm not a virologist, have not felt to particularly affect either transmission or virulence. So there is actually a global database of genomic sequences of SARS-CoV-2 viruses. They have thousands of different sequences in there. I think the main value right now is for epidemiology. So for example, that Iceland study that I showed you, they used the genome sequencing to look at where did the infections come from. So they were, by looking at the genomes of the virus, they were able to say, okay, these people brought the virus from northern Italy, this virus came from Germany, this came from New York, So that's the main role of the sequencing right now, is really to help with epidemiology, but virologists are tracking these viruses because of the concern that they may become more infectious and more virulent. But my understanding is at least the mutations that have occurred so far have not done that. So I wouldn't really, while it's possible the virus circulating on the East Coast has different mutations than the West Coast, I don't think it has any practical implications for us right now.
I see. So the issue in New York is not, it's related to like a structural or a higher prevalence of the virus versus like that strain was.
Right. So it's not due to the fact that they had a different virus. So it's probably a combination of density. So New York City, for example, the population density of New York City is about 3 times higher than Los Angeles. So people are much more crowded. Uh, People much more use of mass transportation in New York than Los Angeles. So it's probably factors like that, plus the fact New York City was a little slow in sheltering, getting to shelter in place. California, San Francisco in particular, but also Los Angeles were were uh, were higher.
Great. Okay. Thank you.
Sure.
We've got another question here that came up in the chat. If you know the mortality rate for the pregnant population, since that's a population we're working extensively with.
Yeah, I don't off the top of my head, other than to say, at least and I haven't looked at this recently, the original data suggested that unlike influenza, pregnant women did not seem to be at increased risk for severe disease or death, though there clearly have been some deaths in pregnant women, and obviously hospitalizations. And at least there was one study early on in the Lancet where they looked at 9 pregnant women and no evidence of transplacental transmission of the virus to the fetus or to the baby after birth. So at least I'm sure there are much newer data. This was back in April, May when I looked at it. At least the early data did not seem to suggest that pregnancy was a big issue, but I haven't looked at it recently, so I don't know if there are better data.
Okay, thank you. Uh,
Sure.
and then we've got a question here from Steve. You mentioned the DNA-based vaccines. Can you explain what those are versus other and how they differ from other vaccines?
Sure. So the traditional strategy for making a vaccine has been to either kill an organism and then inject the killed organism. So that's an inactivated vaccine. Inactivated influenza vaccine would be an example. Um, Inactivated polio would be another one. The second major strategy is to essentially weaken the organism, what's called attenuation, so a live attenuated vaccine. So measles would be an example of that. Oral polio would be a live attenuated vaccine. So you're essentially making it weaker so it won't cause disease, but the immune system still recognizes it and generates an immune response. So those are kind of the two traditional approaches. The next traditional approach that developed later was to take the antigen in particular and stick it in another viral vector. So for example, to take the genomic coding for the hexaminidase protein on an influenza virus and stick it in an adenovirus or some other virus so that you then inject that virus. That virus doesn't cause disease, but it does generate the antigens that lead to the immune response to the virus that you want to target. DNA and RNA vaccines are basically taking that approach, but they're using DNA or RNA to generate the antigen rather than having a viral vector produce the antigen itself. So what you're actually doing is you're you're injecting a plasmid of DNA into the cell such that the cell will then translate that DNA, generate the protein encoded for by that DNA, and that protein is the antigen. And then as that protein is secreted, the immune system recognizes it and generates the immune response. The RNA vaccines are exact same thing. It's that they start with RNA, so the RNA has to be translated back into DNA before you go to the protein. And the Moderna, or however you pronounce it, vaccine, the one that's been in the news that's kind of furthest along, is one of those mRNA vaccines. And in fact, it's the first mRNA vaccine, I think, to be tried in humans.
Wow, I find it amazing that you can take my like 4 years of biology and explain it so succinctly to us. That's very appreciative. I think that's great. I wish I
Sure,
could
no,
do
my
that. I
pleasure.
wish I had that skill, but maybe if I practice it enough, right?
You're probably underestimating your ability or overestimating mine.
Well, thank you so much. I don't see any more questions, so I think we probably at least covered most everybody's thoughts and questions there. So
Great.
I just want to thank you again for such an interesting and useful webinar. It's such a pleasure to have you here. And
Oh, I'm glad I could help.
yeah, it's been really helpful. So last time you presented, I got a lot of comments saying that everybody felt calm and much more like they felt like they understood the situation better. So thanks for providing that for us.
Oh, my pleasure, and thank you for having me, and good luck with all the important work that you and your colleagues do.
Thank you so much. We appreciate it. I will send out the recording of this and the slides to everybody so that if people have questions or want to reference them again, they have a place to find them. And with that, I hope everybody has a great rest of your day and a great rest of your week, and look forward to talking to everybody again soon. Thanks, Dr.
Great.
Brewer.
You're welcome. Bye.
Bye.